But let's talk a little bit about surgical plans for strabismus, management of complications. You heard him talk about perforating the sclera with a needle and the disaster that occurred after that. It sounds pretty dire. I don't think we experience that in strabismus very much. But preoperatively, when you talk with people about surgery, what's the expectation? Parents, of course, wish to have the infant's eyes straightened. I would warn you about a parent or a child who wishes to have straight eyes and not wear glasses after the surgery. This would be a partially accommodative or pure accommodative esotropia, hypermetrope child. And with the glasses on, the eyes are straighter but not completely straight. And with the glasses off, the eyes are more crossed. And so they would like to have the eyes straight and not wear glasses post-operatively. You have to make it perfectly clear to these people that you're going to eliminate the esotropia that the glasses don't eliminate, and that after the surgery, the individual is going to have to wear glasses. If you don't do that, you may see a lot of crying post-op on the part of the child and the mother. And then the adult, of course, who has diplopia and wants to get rid of it. And can the problem be solved with surgery? Well, perhaps. If it can't be, then don't do the surgery. So what are the risks? You know the risks of anesthesia, general, local. We have had a case here at Wills where an individual had an uneventful recession of the medial rectus muscle and ended up with optic atrophy and no light perception in the eye. There is a risk. And if you explain too many of the risks to people, they might not want to have the surgery. The loss of the eye, that has happened. Loss of vision has happened. So prior to sedation, it's the same thing with any other kind of eye surgery you do. You identify the patient. You have a clear understanding with them preoperatively what eye are you going to operate, and make sure that the spouse or the significant other understands that as well, because if this individual who's just had surgery comes back into the recovery room and under the influence of medication says something like he operated the wrong eye, the spouse may flip. So you have to have a clear understanding with the people just exactly what you're doing. In my career, I explain to people, for the most part, it really doesn't matter in most cases of strabismus whether you do one eye or the other eye. And I explain to them that sometimes we find abnormalities in the muscle, which then makes us want to do the other eye. So I usually had a clear understanding with them preoperatively that I would operate on one or both eyes, and I never had much problem with that. But if you have them sign for the right eye, you can't switch to the left eye in the middle of the surgery. You have to get all of this straight ahead of time. And then, of course, mark the eye. Identify the patient in the OR. Put an X over the brow of the eye you're going to operate. That helps if you do that when the person is awake, because it's reassuring to them that you're probably going to do the correct eye. And then while the OR team is preparing the patient, what I think is really good is to look at the instrument tray. Now, you just heard a lecture before me talking about hunting for instruments and sutures during the procedure. What you really want to do is make sure that you have everything you need for that case right there on your Mayo stand, and it's a perfect opportunity during the prep for you to do that. You want to make sure that the scissors work and that the needle holders work. You don't want to have to ask for another needle holder in the middle of the procedure. Make sure that the sutures you want to use are on the tray, and then begin the procedure. Well, complications during surgery, operating the wrong person. I suppose that could happen, but I've never seen it here, but it's listed in your manual. Operating on the wrong person, well, ahead of time you need to meet and talk with the adult patient. I do recall as a resident at the old hospital on Spring Garden Street, what we did was we blocked the people out in the hallway. They were not hooked up to an EKG machine at all. They were out there on the litter. We blocked them so that when we took them into the operating room, they'd be blocked. So one of the residents ahead of me, I was a second-year resident, he was a third-year resident, he wheeled his cataract patient into the OR, and the attending, who'd never seen the patient before and had just come in to help the resident do the surgery, said, "Well, doctor, what do we have?" And the resident said, "We got so-and-so, we're going to remove the cataract." So they removed the cataract. The person went into the post-op room. And then Dr. Moberger, who was a chief, came up to the OR to do his private cataract case. But the resident and this other attending had just done it as a service case. And Moberger really flipped. The resident, who was a very calm person who never got upset about anything, said, "You know, Dr. Moberger, why are you so upset? Everything went well. You've got 30 minutes now that you didn't have. Go in and have a cup of coffee and sit down and relax and don't worry about it." And Moberger was so flabbergasted at this resident's attitude that he accepted it, and everything turned out well. So yes, it is possible to do the wrong person. Is it possible to operate the wrong eye? Yes. That has happened here and on our service. The operating surgeon went into the post-op area after the surgery to see the patient who was recovering. She was a nurse, and he noticed that the wrong eye was patched and asked her, "Why is this eye patched?" And she said, "Well, that's the eye you operated," but he was going to operate the other eye. So she was not particularly happy about that. You have to mark that eye and you have to know what you're doing. Don't forget, you look at the person in the clinic and you examine them, but on the operating table they're 180 degrees from the way they are when you face them. So you have to make sure that you mark that eye. If you're going to do the right eye, it's going to be different when they're on the operating table. And don't let someone drape the patient before you get there, because if the drape covers that mark on the forehead, it may obscure the mark that you had placed there. So operating the wrong muscle, does that happen? Well, that can happen. So I advise you to bring the patient's chart to the OR if you have 6 or 7 cases that morning. It's easy to confuse one patient with another. And I'm going to show you an example of an individual in a moment. Remember your spiral of Tilot, which you're familiar with, and it is possible to hook the inferior rectus or part of it when you're actually trying to operate the medial rectus muscle. So know your anatomy. Here's the spiral, and as you know, the medial is closer to the limbus than the inferior rectus, and the lateral rectus and the superior rectus. The distance here between the inferior rectus and the medial rectus is not very much, so it is possible when a hook is placed, it comes down here and gets part of the inferior rectus as well as the medial rectus. I have seen that done. So performing the wrong procedure. Okay, here's a guy. I'm going to ask you what you would do after this. Here's a fellow, has a right hypertropia. So the treatment would be to recess the right superior rectus and resect the right inferior rectus. The patient left the operating room, and while he was in the recovery room, the surgeon was dictating the operative report. And as he was describing having resected the right superior rectus and recessing the right inferior rectus, suddenly a light turned on, and he realized what he had done. What should he do? Does anybody have a suggestion? What would you do? He resected the right superior rectus and recessed the right inferior rectus.
You could keep them patched, tell them you're going to bring them back in a week to do the second part of the operation.
Well, that's what the surgeon did. And undid what he did, and everything turned out all right. You've heard this talk before. Okay. Hemorrhage during the procedure. Well, I was in the OR one morning, and a friend of mine up in Phoenixville called me, and I'll show you what happened to him. Hemorrhages are unusual. Sometimes you place the needle through the tendon of the muscle, and you hit a vessel and it bleeds. Well, you just have to wait until the bleeding stops. You can often control that, but not all the time. There you are. What he did was he placed his sutures and he got a hyphema. So what would you do when that happens? He called me on the telephone and he said, I got a hyphema when I placed the suture. What would you do? Well, this is not the kind of hyphema you deal with like in the emergency room. These are hyphemas that go away and don't need any specific treatment. So I told him, go ahead and complete the surgery and don't worry about it, which he did, and everything turned out all right. He just put that suture a little bit too deep. Perforation of the sclera with a needle, you've just heard in the last lecture about that. There are certain forceps for grasping the superior rectus that prevent what Dr. Katz told you happening, that prevents that from happening, and those forceps work quite well. One of the problems with patients on the operating table, especially children under general anesthesia, is that you never know when that child is going to buck, when that anesthesia gets a little bit light. So you never, ever in eye surgery want to have the point of your needle pointing toward the eye. Never. Because if they come forward, something's going to happen. You're always going to lie the flat surface of the needle on the sclera and then enter the sclera in a horizontal way, never dipping down and then changing course. So you can prevent that from happening. There was a study done a number of years ago in Washington. The patient's eyes were dilated preoperatively, and then indirect ophthalmoscopy was performed after surgery, and the depth of the needle in the sclera was evaluated for residents, fellows, and the staff. And it was interesting that the depth of the passage was deeper for the residents, less for the fellow, and even less for the staff. So there is a possibility of going a little bit too deep. And sometimes if you see where the surgeon has actually perforated the sclera and passed the needle and the suture out, if you look at that person months, years later, it's like a tuft in the vitreous. It looks like a toxocara sort of thing. You'll see a scar out in the periphery, and you'll see this little filamentous scarred area, and doesn't cause any problems for the most part in children. What would someone recommend you do? Well, some people recommend putting some cryo around the hole, place antibiotics over the hole and under Tenons and conjunctiva, and use post-operative antibiotics. Usually these things don't cause any problem, although there have been some cases with endophthalmitis. When you're marking the sclera as to how many millimeters you're going to recess, don't drill with the tip of that calipers. Just stroke lightly. Just see your line on the sclera, but don't come in vertically and make a point, because sometimes the tip is very sharp and it'll perforate the sclera. Cutting the sclera with the loss of vitreous, well, if you do that, you're going to have vitreous in your wound, so you're going to consult with the retinal surgeon. But Rudolph Abele was a cataract surgeon, and he devised the scissors you see here that we use in strabismus surgery. And these scissors prevent the sclera here from pouching up between the blades. So you just want to make sure that when you cut that tendon off the sclera, you're not cutting into the sclera. Losing a muscle. Well, here you can see the needle is passed through this capsule that's on the surface of the tendon, and you can see here's the tendon, but this is a capsule. So this surgeon has passed this needle incorrectly through tissue that is really the capsule of the tendon. So what you want to do is get into the depth of the tendon, as you can see here. Make sure you're in that tendon. And then if you pass your needle back through, as you can see here, and tie that knot, it's not going to be possible to lose the muscle because of improper placement of the suture. Then you leave yourself a millimeter or so between the passage of the suture and the sclera so that your scissors don't cut the suture. There's nothing worse than to be holding the hook, the sutures, cut, and then all of a sudden you've got two sutures in your hand and the muscle has slipped back. So you have to be very careful when you cut that tendon off the sclera. And again, this just shows the passage of the suture and the needle through the tendon. In the Academy manual, as I read the resection technique, they talked about placing the suture, as you can see here, and tying the knot. Make sure you always tie a square knot. And then cutting the tendon very close to the suture. I think that's pretty dangerous. What you want to do is give yourself some room between where you cut and the line of the suture. If you had a lost muscle, one mistake that people make is they think that the medial, for example, comes back down in here somehow, and so they fish back along the equator of the sclera, thinking the muscle's back there. Well, it isn't there. It goes out through Tenon's capsule out into the orbit. So if you're going to look for it, you go out through Tenon's and not along the sclera. You've read in your manual and on the board review about how many rectus muscles you can sever from the sclera without getting ischemic anterior ischemia. Well, you've got two ciliary arteries, two, and one for the lateral. So you can do two rectus muscles at one sitting. And if you do more, you run the risk of anterior segment ischemia. So you don't want to do three rectus muscles at one sitting. On the other hand, you can do two rectus muscles, the superior oblique and the inferior oblique. So you can actually do four extraocular muscles and not have any problem. The question on the board is how many rectus muscles? And they don't include the obliques. Do you have any questions about complications? Unlike glaucoma surgery and cataract surgery, strabismus surgery really does not lend itself well to having complications. If you're careful and have a good technique, you're not going to have any problems. There's nothing you can do about cataract surgery. You can be the best surgeon in the world. The posterior capsule just sometimes breaks. Sometimes the vitreous comes forward. I don't know of any surgeon who hasn't had complications during cataract surgery. But I do know surgeons who've never had any complications during strabismus surgery. There's just a difference between working on the outside of the eye and the inside of the eye. Well, if you don't have any questions about that, I thought I would just review some information. You know, unfortunately, we have very little time to sit down and discuss interesting cases in the OR. Sebastian, you heard this talk already?
Yes,
okay.
I believe so, yeah.
Yeah, so the third years have heard this. Do you mind if I just quickly review this, and then I want to...
Great.
So, okay. When I finished fellowship, I had a patient referred to me, and Vic, what do you think this child has right here?
Looks like left hypertrophy.
Left hypertrophy, okay. The child was referred to me for ptosis surgery, the right eye. But as you can see, when the child fixates with this eye, the ptosis goes away. So you have here a case of a left hypertropia that's greater in right gaze and less in left gaze. So head tilts have been known throughout history. Alexander the Great, as you can see, had left head tilt, left face turn, chin elevation. The left side of his face is less well formed than the right, so it's probably some sort of congenital problem. The problem, and Steve Newman at the Kogan meeting, interesting after I gave this talk, he talked about most of the cyclovertical muscle palsy he sees as a neuro-ophthalmologist at the University of Virginia actually are thyroid cases. But what he didn't understand, and what a lot of neuro-ophthalmologists don't understand, is that the three-step test is specifically to be used in those cases in whom there are no other causes for the hypertropia. For example, if you have someone who comes in and has an orbital floor fracture or a car accident, you know why they have the problem. If they have a blowout fracture of the floor of the orbit, you know why the inferior rectus is not working normally. So if they have retraction of the upper lid and they have proptosis of the eyes, you know they have the thyroid disease or some orbital problem. So we have excluded all those people, and we're talking about individuals who otherwise seem to be normal, who have full rotations of both eyes and yet have a vertical deviation. So we have to properly apply the use of the three-step test, and a lot of people don't understand that. So we're talking about four muscles, and the inferior oblique and the inferior rectus, for the most part, can be eliminated, and the quarrel is always between the superior rectus and the superior oblique. Now, if I asked you what is the yoke muscle of the left inferior oblique, you can quickly tell me it's the right superior rectus, can't you? Anybody asks you their yoke muscle, well, here's the way. You want the yoke muscle of the left inferior oblique. You change left to right, inferior to superior, oblique to rectus. Takes you 5 seconds. Nothing to memorize. It's just very easy to determine the yoke muscle of any muscle just by applying those three rules. Here you are. Right superior rectus, left inferior oblique. The problem with the superior rectus and the superior oblique is that if an individual, let's say, has a right superior oblique palsy, the right eye is going to be higher, and the inferior oblique is going to overact. Over a period of time, the inferior oblique may undergo what we clinically call contracture. Contracture is not a histological diagnosis. You cannot see it under a microscope when you look at the muscle. It's a clinical term. Just like if any of you have ever had a broken leg or something and you've had your leg in a cast after the cast is removed, it takes your ankle a long time to get back to what it was before, because those tendons have undergone some sort of contracture. So Chavas termed this the inhibitional palsy of a contralateral antagonist. So it may be with the passage of time that the individual with the superior oblique palsy actually has a greater deviation in the field of action of that contracted inferior oblique. Now, here's an example. Here's a man who's had sinus surgery, so we know his superior oblique has been operated. His superior oblique does not depress the eye in adduction, and as a result of that, his right eye is chosen for fixation. Herring's law, yoke muscles. The right inferior oblique requires less innervation to elevate the right eye in adduction. By Herring's law, the yoke left superior rectus receives the same innervation, but it is opposed by the depressing effect of the left inferior rectus, so the left superior oblique appears to underact. Here you see it clinically, this individual. He has a left hypotropia, and when he looks up and to the right, does he have overaction of the right inferior oblique or underaction of the left superior rectus? So this was a controversy. Bielchowski came from Europe to Dartmouth in the late 1930s, and he stressed the fact that strabismologists have to take into consideration the torsional effect of the cyclovertical muscles. So we talk about intorsion and we talk about extorsion. William Thornwall Davis was an ophthalmologist in Washington, D.C., and in early 1940s, he went to the New York Academy of Ophthalmology meeting. This was a meeting all the ophthalmologists in New York City went to, and it was held regularly, and different cases were presented, and then everyone was able to get up and discuss what the speaker had presented. And so William Thornwall Davis discussed the problem of how do you clinically differentiate between the superior oblique and the opposite superior rectus. It obviously required some sort of clinical reasoning, and so Alexander Duane, very well known for his syndrome. James Watson White was a very well-known strabismus surgeon in New York surgery, and Harold Brown presented their evidence that most of these cases were superior rectus palsies. And when I came back from fellowship, the neuro-ophthalmology service at Wills had no ophthalmologists on it. They were all neurologists. And when they categorized these people, the majority of them had superior rectus palsies. Very few had superior oblique palsies. They had no concept of head tilting and things like that. So at the discussion, we realized there's eminence-based medicine and evidence-based medicine. Eminence-based medicine, I'll give you a perfect example. At the Kogan meeting, it was presented that the head of ophthalmology at the University of Denmark did not allow people with optic neuritis to be admitted and given intravenous steroids because he didn't believe the studies. So because he was the head of the department, everybody did what he told them to do. So it was eminence-based medicine. And so James Watson White got up and he said, when I first worked with Duane in 1914, he and Bielchowski were discussing this, and I was in the midst of it. Bielchowski never convinced Duane. Duane never convinced Bielchowski. Dr. Davis has not convinced me, and I shall not try to convince Dr. Davis. So James Smith said to the Academy, would someone please solve this problem and give us some guidelines? So Francis Adler at the Jackson Lecture to the Academy in the 40s discussed the role of the superior rectus and inferior rectus muscles and discussed, as you can see, if you look at the superior rectus here, it's going to adduct the eye, elevate it a little bit, and perhaps intort it. But if you turn the eye outward 23 degrees, it's going to be a pure elevator. And Adler reviewed the actions of the extraocular muscles and then said, you have to incorporate the torsional aspect of this as well as the vertical action. Now, the problem was that you can't use the head tilt test to make the diagnosis. Torsion is not very accurate. So Parks came along and put together a three-step test and talked about evaluating the cyclovertical muscles by using their greatest vertical action. And so the normal vertical meridians, when you tilt your head to the right, you see the right eye intorts, the left eye extorts, and when you tilt your head to the left side, the vestibular mechanism is activated, and so the 6 to 12 meridians right themselves. So in a superior oblique palsy, the eye goes up, it extorts, you've got a hyper, and using the Bielchowski head tilt, you can see now we have tilted this individual's head to the left shoulder. By doing that, the 6 to 12 meridian is now righted. And you have two intorters of the left eye, and they intort the left eye, and one's an elevator, one's a depressor, and so the vertical doesn't change. But when you tilt this individual's head to the right shoulder, the paretic muscle, you can see that the extorters here have righted, or excuse me, there, you see how it, 6 to 12, and they balance one another over here. But on the other side, the intorters of the right eye attempt to intort the right eye, and the superior rectus elevates the eye, and the superior oblique, being weak, loses out. So what Parks did was he incorporated all of this together. And we have the individual, as you can see here, and we have them look to the sides because we want to evaluate the muscle in its position of greatest vertical action. Example, the normal. Okay, if you have a left hypertrophy, as you can see here, it can be a weakness of the depressors of the left eye, or a left hypertropia is the same as a right hypotropia, so it can be an elevator weakness of the right eye. So just the fact the person has a left hypertropia tells you it's one of four muscles. If you have the person look to the left, the hyper is less. So if you eliminated the two cyclovertical muscles whose greatest vertical action is in left gaze, and when you have the individual look to the right, the hyper is greater. So it has to be one of two muscles whose greatest vertical action is in right gaze. And here's the dilemma. You know, Herring's law, yoke muscles, inhibitional palsy of Chavas. How do you make this diagnosis? Which one is it? So you tilt the head to the right shoulder, the hyper is less. You tilt the shoulder to the left, and the hyper is more. So you've confirmed the fact that it's the left superior oblique. We will never know whether Abraham Lincoln did or did not have a left superior oblique palsy. Now let me just show you the real world that you deal with in the emergency room. You can go crazy. You remember this woman, Sebastian? Yeah. Well, here's a woman. She had vertical diplopia for about 2 months. And as you can see, she's got a right hypertropia, left hypo, if you want to call it that. Vision's good. So when she looks here, her eyes are level. When she looks here, she's got a right hyper, and here's overaction of the inferior oblique, underaction of the right superior oblique. Now, you do the 3-step test, and she's got a right hyper that's greater in left gaze, greater on right head tilt, confirms the diagnosis of right superior oblique palsy. But let's let her have this done again under different circumstances. She's got a right hypertropia in all 3 positions. Now, what is different between what you see here and what I just described? The difference is that previously she was sitting upright. And when you tilt her head to the shoulders, you activate the vestibular mechanism. In this instance, she is lying on her back, looking at the ceiling. And you've eliminated the effect of the vestibular mechanism. Therefore, when you see somebody car wreck on a litter in an emergency room and they're complaining of vertical diplopia, you do not want to use the 3-step test while they're on their back because it doesn't activate the vestibular mechanisms. Someday, if you want me to, I'll explain to you how I obtained these photographs. That's a different story. But I have to thank Sebastian. I was standing over her looking straight down, and he had a hold of my belt, holding me from falling over as I was taking one step forward, and I would have fallen right over. Now, here's the real world in the emergency room, and this is the last case, but this is an interesting woman. She came in, okay. Vertical diplopia for 1 month. She had a Fresnel prism in the left lens here. Her English was not all that good. And she had been seen by an ophthalmologist who told her she had double vision and treated her with Fresnel prism. She had a small blood vessel disease problem in the brain, taking all these medications. 2100, so you can't really do a really good cover test because to do a cover test you have to have someone who can fixate really well. And so we have to have some other way. So I know a lot of you are locked into the double Maddox rod, but I'll show you another way to do this. So I removed the prism, and then I asked her to look at the light on the end of the wall. Okay, now you're dealing with an older woman, doesn't speak English very well. You're trying to make a diagnosis. With your glasses on and looking with both eyes together, how many lights do you see? 2. Question 2. With the cover over the right eye, how many lights do you see? 1. With the cover over your left eye, how many lights do you see? 1. So I have at least established the fact that she truly has binocular vertical diplopia. And then we proceed. Are the lights side by side, or is one on top of the other? She did have tilting of the image, which fouled everything up, but I wasn't interested because that's not going to help me make the diagnosis. So I had her look at a muscle light. Okay, so we put a red glass over the left eye. So the right eye sees the white light, the left eye sees the red light. Next question, is the red light higher or lower higher. That tells me that the left eye is lower or that the right eye is higher. Okay, now, looking at those two lights, I'm going to cover the right eye, and I want to know which light disappears, the red one or the white one? The red one. So this indicates that the left eye is lower or the right eye is higher. Okay, so we don't need prisms here. We're just trying to make a diagnosis. So a right hyper means she has a depressor weakness of the right eye, which is the right inferior rectus, the right superior oblique, or she could have an elevator weakness of the left eye, the left inferior oblique or the left superior rectus. So two of the four muscles have a greater vertical action in right gaze, the right inferior rectus, left inferior oblique. Two in left gaze, the left superior rectus, the right superior oblique. So now I have her look to the right. Looking to the right, are the lights closer or farther apart? Closer. Looking to the left, are the lights closer or farther apart? Farther apart. Okay. So it's a muscle whose greatest vertical action is in left gaze. So again, we have the choice of two muscles. Next question. With your head tilted to the left, are the lights closer together or farther apart? Closer. And with your head tilted to the right, are they closer or farther apart? Farther apart. So it's a right superior oblique palsy. So I offer this to you because in the emergency room situation, you're just trying to find out what the diagnosis is. The prism measurements don't mean anything for this kind of thing. And this is one way of dealing with a very difficult patient who, if you ask her the questions in a way she can understand, she'll respond appropriately.